My name is Marisa Klein-Gitelman. I'm a pediatric rheumatologist, and I work in Chicago at Northwestern University Children's Memorial Hospital. And I've been asked to talk about, well, I got an interesting title. Is it up? That was the title I was given, so I left it there. What I'm going to do is talk to you about outcomes of adults. And I guess I should say, before I go further, I have these disclosures, which means that I participate in activities with these companies. So what we're going to do is talk about what we know about adult lupus a little bit, outcomes, because we really don't have much information about pediatric outcomes. And there's a great need for a registry of pediatric lupus patients that can be followed into adulthood so we learn more. And actually, in the United States, with the latest set of incentive grants from the government, the CARA group has developed an opportunity to start a registry, and hopefully we'll learn lots more. And after I review the adult data, we'll look at the pediatric data. If there's things that I'm saying that you have questions about, please interrupt me. I would rather you understand what I'm saying and be able to follow. So we're going to talk about adult risk factors. Well, the first thing that people can't help when they get lupus is whether they're male or female. And it turns out that male patients have worse outcomes in general. And I put up a picture of one of the more famous male lupus patients. That's a singer named Seal. The latest data comes from a wonderful cohort that's been going on for quite a while called the Lupus and Minorities Nature versus Nurture cohort, or Lumina. And when they looked at the men that were in that cohort, there were 63 men. They were mostly Caucasian, and they had increased rates of kidney disease. They had more of this lupus anticoagulant, this antibody that's associated with heart attacks and strokes and blood clots. They had more tobacco and alcohol use than women, but they had less musculoskeletal disease. There are these criteria that you've learned about that we use as classification for lupus, these 11 criteria that the American College of Rheumatology uses, and men seem to accrue these criteria more quickly and more intensely than women do. Generally, patients of Hispanic, African, Afro-Caribbean, South Asian, and Chinese descent are younger when they get ill with lupus. They have more kidney disease, and in some studies, more hematologic disease, or their blood counts are abnormal, more fluid around their heart or their lungs, and they have more neuropsychiatric disease. And I've kind of placed some squares in those areas of the world. Not only do they have more of these problems, but they seem to accumulate rapidly again, and there's a higher mortality or death rate. And the question here is why? And so is it genetic? Is it access? Or is it within different ethnicities, there are different beliefs and perceptions about illness and how you get better that cause these things to happen? So beliefs and perceptions are important. People choose to have different diets, they have different coping strategies, and they go to more traditional or Western medicine type treatments based on how they were brought up. It will reflect in how early they get diagnosed with lupus. It will also dictate how their treatment goes. And it's not only whether they get there, but their willingness to accept the diagnosis and the treatment plan, because in different beliefs and perception systems, people will look at symptoms differently. They will decide whether they need to access healthcare in a different way. They may have different explanations for their symptoms and recognition of signs. Their lifestyle will affect their experience and their attitudes towards their healthcare, And of course, their disease knowledge and understanding of the treatment may be a reflection of their background and how they interact with their physicians. Well, it turns out, and the themes that you heard from Dr. Amigo will be played out here, that another important factor in outcomes is adherence to your medical regimen. It turns out about half of us with chronic illness take their medicine. About half of us don't take their medicine regularly. And there may be a variety of reasons why that occurs. In one study in Michigan, there were two distinct lines of reasoning or outcomes for why people didn't take their medicine, but they resulted in the same outcome. And one was more of lack of trust with the provider and perceived inefficacy of the medications. They didn't work very well. And the other was that people were depressed. They had poor memories. They had concerns about their medications, side effects, and they needed help. They had too many things to do. They had to provide elder care or child care, and they couldn't get to their medication. It turns out when you don't take your medicine, sometimes you end up going to the emergency room or getting admitted to the hospital more, and that is more expensive, but it also exposes you to more other problems, which we'll get to next. And it turns out that patients who are less adherent to their medical regimens get more kidney disease, but there's no real link to whether it gets you in further trouble, and that is yet to be learned. There is a medication adherence self-report index that's been developed, and at some point you might come across one of these where you get your medical care. And it's been actually, and we'll talk about it in a minute with kids, been validated in kids as well. And these were some of the reasons when people have studied adherence, why they are good at taking their medicine or not so good at taking their medicine, and things that we just talked about. People will take their medicine because they're fearful of their illness and they don't know what else to do. They're not sure about their illness and they're just going to do what the doctor says. And they have some kind of obligation or responsibility to others, so they better just take their medicine. It turns out that poor adherence has to do with communication. It has to do with understanding as well, things that we talked about, depression and memory, but also with concerns of long-term use and side effects, taking medicines, many medicines, changing medicines, adding medicines, wondering if complementary medicines might work better, and prayer. And prayer is interesting in that people might think about, well, maybe I don't need to take my medicine because I was fatalistically going to get this disease, or maybe people pray a lot and that helps them take their medicine better. So that can go either way. And it turns out different medicines are taken with different adherence. I know that a lot of people are concerned about diet and outcome. There's really no data about diet and outcome for lupus yet. There are some mouse models. We use mouse models to study lupus, as you've been hearing. There's a mouse model for atherosclerosis and high-fat diets. And you've heard just that that's not a good idea, that you want to keep your heart healthy. There's also a mouse model that talks about isoflavones, and those are something found in soy and some other foods, and they seem to reduce inflammation in this animal model. And so there's a suggestion that those are helpful, but it hasn't been proven in people. There was one small study looking at whether taking a lot of vitamins and minerals above and beyond a normal healthy diet was helpful, and it really wasn't. But it was a small study. Exercise. So exercise is heart healthy, it keeps your weight down, but exercise probably does a lot more for you than you realize. It improves your activities of daily living, it helps your quality of life, and it has a direct effect on inflammation. In the US, there's a report every year about how many people die and what they die of and why. And so they die of things like cancer and heart disease, but then why do they get the cancer and heart disease? And it turns out that physical inactivity accounts for 15% of the deaths in the United States. That's a pretty dramatic number. And it turns out that kids, which we'll get to in a moment again, as well as adults, are being more and more sedentary, and there's an increased risk of adult onset diabetes, and both adult onset diabetes and cardiovascular disease are associated with chronic inflammation. And exercise reduces chronic inflammation. We have come from rheumatologists who say that you should protect your joints, you shouldn't move, to many investigators proving that you feel much better when you move, you have less pain, and you're more mobile. And then infection is clearly a bad thing for lupus outcomes. And we had mentioned that being in the hospital was a bad thing. It turns out hospital-acquired infections cause a lot more trouble for lupus patients than a community-acquired infections, so we want to stay out of the hospital. And this one study here showed that survival rate after a serious infection dramatically reduced outcomes in lupus. So it's important to stay healthy and out of the hospital. So this is an international lupus meeting, and I just want to point out that poverty trumps all. This is a picture of the slums in Soweto, and in Soweto, if you have lupus, about 5 years after you've been diagnosed, a quarter of your patients have passed away from infection, kidney failure, or who knows, because they died at home and no one knew what they died of. A quarter of your patients are lost to follow-up. You can't find them, so you don't know what happened. And then you're taking care of the other half. And even in the Lumina study, which I had mentioned previously, although kidney disease is the biggest predictor of poor outcome, if you add poverty in, that is even more striking. So access to health care, being able to see a doctor, is really important. And that's true for both kids and adults. So what are the differences between kids and adults? Well, it turns out kids generally get sicker with lupus. They have more serologic abnormalities, they have higher anti-DNA antibody levels and rates, they have more low complements, things that you might be familiar with that your doctor measures. They have a bigger dose of steroids that are given to them to control their disease. We have more male patients. There are more male patients with lupus before puberty and after menopause. They have, at diagnosis, more kidney disease, more neurologic disease, more blood problems. And if they have a high disease index, the SLEDAI disease index, without those, within the first year, they're likely to get those problems. But it gets more complicated than that because children are growing and they're developing. And so all of these things and the treatments we have to give them are in the midst of all of this development. It's affected by the family dynamics. It's affected by both the effect of the disease and the medication on body image, which is just being formed. There's an adjustment to diagnosis. There's issues with peers and how they perceive you. And we're trying to foster independence in our older kids, and here comes this disease that makes them dependent. We want them to go to school to foster their independence and to keep them active. In the US, there are specific plans, and I'm sure there are in many places, to help keep kids in school with chronic illness. And lastly, we might note that we still have maturing immune systems, especially in our younger patients, that are now being devastated by this disease, and there are hormonal changes. So I mentioned all the challenges of being an adolescent. They're in the midst of trying to figure out what is really true and what is possibly true. They have problems with time. They are struggling with being independent or conforming to the group. They are experimenting. They are anticipating that they can do a lot, but they often get paralyzed by the work when it comes their way. They are questioning authority. They are very ideological. And they're also developing sexually, and they're developing their identity in that way as well. So that's a lot that they need to do, and unfortunately, chronic illness has a major toll on that. So, and family function, as I mentioned before, is a critical piece here, because how well the family's connected and how the family perceives illness is reflected in how the child will do. And it also is specific to the child. Some children internalize all of their anxiety, others externalize and have behaviors that are interesting, and of course, their own personal self-esteem. It turns out that kids with arthritis seem to do pretty well compared to their peers, but kids with lupus have a lot more challenges. We also note that kids have a lot more depressive episodes, especially in high school. They have beginnings of the risk for mental health disorders, which being sick with a chronic illness might push them towards. In adolescent, chronic illness imposes this lack of independence and control during this important time. They are much more emotionally intense, and they have many social pressures, and this all leads to poor adherence, school refusal, and risky behaviors. So we have fewer patients with mild disease. Kids have more severe disease. They have chronic low-grade activity with unpredictable, often severe flares, perhaps or maybe not perhaps associated with when they take their meds. And they have persisting problems in their kidneys, in their brains, and in their hearts. And we have a lot of concern about their vascular health as well. So this is a typical teenage meal. Not exactly what we were talking about earlier: hamburgers, French fries, and milkshakes. We need for our kids with lupus to have low-fat, low-salt, and high-calcium meals. So this is a big challenge and something that would help them with their outcomes. There is absolutely no data about diet and outcomes in pediatric lupus. You hear about bone health, you hear about steroids causing osteoporosis and the importance of exercise. When you look at this is a typical bone density over time, and what you'll notice is that between the age of 10 and 20, we're making bone. And this is when these kids get lupus, this is when they go on steroids, this is when they don't feel good. And so it's really important for us to be talking to them about all the things that they can do to make sure their bones get strong enough by the time they're in their mid-20s, so that when they start losing bone naturally, they're not at that bottom curve, they're more close to the top curve so that they don't end up with fracture. And it's hard, as you saw, time perception is a problem during adolescence. It's hard for them to focus on what happens when they're going to be 50. There are just beginning to be some studies about pediatric rheumatology patients and exercise more in the arthritis realm. Children are far more sedentary than they used to be with the small screen time, meaning their iPods, their iPhones, their computers, and TVs. And if it goes over 2 hours a day, there's a serious increase in the risk of diabetes. This little cartoon on the end there, I don't know if you can read, but it basically, these kids are eating food, potato chips and stuff, and they're talking about that they need to exercise more, so maybe they need to chew faster. In this review about exercise in kids with autoimmune diseases, and I think this is also very true of adults, there is a whole cascade effect with lack of physical exercise and physical inactivity. Because when you're inactive, you get tired, your muscles aren't being exercised, they get weak, they begin to atrophy or thin, then they start to dysfunction, and you're not moving, so you start resorbing bone, you gain weight, and you have a major motor control disturbance. And if you exercise, you stop that whole cascade. So it's very important as all people who get sick with chronic illness and don't feel well to promote exercise. And it turns out there's research actually that suggests that muscle contraction actually puts out these immune hormones that you've been hearing about in the Congress that reduce inflammation. So it's not even just the exercise actually reduces inflammation. That's a little photo from the NIH website that says there's nothing healthy about a tan. We need to remember that 90% of your lifetime sun exposure happened when you were a kid. So now we have kids with lupus, and it's a big fight. They want to look like their peers. They want to appear tan like their peers. You work very hard to get them to use sunscreen and be careful. And I will never forget one of my patients who wanted to look good for his prom. So he didn't go out suntanning, but he went to a sun booth and got a lovely rash that he went to prom with on his face. So we need to work with this. And I had mentioned this medication adherence issue. Kids are interesting. They will use their steroids to make themselves feel better, so they'll take them more when they're feeling bad, and they won't take them at all when they're feeling well. They're a little more compliant with their steroids than they are with their Plaquenil and their other disease-modifying agents. And family and social support are very critical to how well they adhere to their medication regimen. From this paper, it came out of Dr. Bruner's group at Cincinnati Children's. These were the kinds of things that kids reported why they didn't take their medications. They forgot, they ran out, they weren't at home, they were too busy, they didn't have any money, they didn't feel well, they felt too good, and there were too many pills. And these are things that would help them do better. A pill box, and that's like the first thing there for everything, a pill box. A task list, explanations, messages to take your medicine, nurses calling the house to remind you to take your medicine, nurses calling your house to remind you to refill your medication, regular calls by the nurse. But there is also that group where nothing helps. I don't want to take it, it doesn't help. And that's really the group that we want to pay the most attention to. But everything else there is fixable. The next thing I had mentioned was growth, and the big issue with growth is steroids. Steroids have a big toll on growth in terms that they stop you from growing if you're small, if you're in the middle of growing. Kids in elementary school have much more problems than kids in high school. And it suggests that we need to have alternative strategies and manage this better. Here's one of my patients. This is a graph of his body mass index. Body mass index is a composition of your height and your weight. So when we talk about kids, we talk about percentiles because kids that are 5 are little and kids that are 15 are much taller. So we can't directly compare the numbers. But if you see, when this boy first got sick, his height was at the 27th percentile and his weight was at the 40th percentile for age. And we gave him steroids. And his body mass index went up. His height fell to the 13th percentile over time because he was not growing. And his weight increased to the 60th percentile. And then as we were able to taper his steroids, he went back to the 26th percentile for height. And his weight has varied a little bit. And kids' weights do vary. They tend to gain a little weight and then grow, gain a little weight and grow. So we weren't too worried about that. But it's a profound effect. And this is the effect of both inflammation and steroids on a child's body. So it's a bigger challenge that we have. Infection is also bad for kids. They tend to have more organ failure when they get a lot of infections, and that's not surprising. Cardiovascular risk is also important in pediatric lupus. There was a study, which we're going to go over in a minute, that compared adults who had childhood onset to adult onset lupus and what happened to them. And it turns out that the rate of myocardial infarction in these groups is the same. It's just that if you started with childhood lupus, you're having them at 30 instead of at 50. The APPLE trial is a multi-center study that was done in the United States to look at cardiovascular health and looking at whether atorvastatin is useful in reducing the plaque that people accrue when they have lupus. And the comment that Dr. Amigo made about azathioprine is something that's being studied in that study as well, and we will have some data on that shortly. That study just got locked and the data is being analyzed. So Dr. Hirsch is in San Francisco, and she compared 90 subjects who had been diagnosed with lupus before the age of 18 to almost 800 people who had been diagnosed with lupus after the age of 18 to see what the differences were. And it just underscores what we started with, that childhood lupus has a higher frequency of male patients. In this population, Latino patients, they were more likely to have kidney failure or a kidney transplant, and they had this higher rate or equal rate of myocardial infarction at a younger age. So for kids, chronic persistent disease ends up with poor outcomes, so we tend to be more aggressive, at least at this time until we figure that out. We worry about organ failure and infection. We worry about bone death, something called osteonecrosis, which can lead to joint replacement. We really don't know about malignancy. That is an issue in adult lupus. I've demonstrated to you that growth was important, and then we're worried about these chronic effects of therapy and inflammation. So I came up with this. And how can we take steps to minimize the long-term risks for medical care of children with lupus? And I came up with this acronym, I can lead my care. I can lead. I for information, C for communication, A for access, and N for new therapies that we're hoping for. Can help us manage our lupus if we're eating correctly, that we're adhering to our medication regimen, and we're exercising well. And so that's what we have come to, and that's what we've learned from adult care and from pediatric care at this time. And what we need to do is move forward with more studies and more registries so that we can inform you better over time. Thanks.